Hi, welcome to Cinnamon Med Note. In this video, we are going to talk about painful perianal conditions under general surgery. Before we start, let us look at a case trigger. 55-year-old man presents with severe anal pain of acute onset. He has been experiencing anal bleeding for 3 months, which he noted dark red stool and bright red blood on toilet paper. You may pause this video for a while to think of the questions you would like to ask in this patient and certain conditions you would like to rule out in this case. Here's the table of contents in this video. First of all, we'll talk about some key points in history taking and physical examination. Next, we'll discuss some differential diagnosis for this chief complaint. And thirdly, we'll talk about some investigation and management for the differential diagnosis. Let us look at a few key points in history taking and physical examination for a patient who come in with anal pain associated with bleeding per rectum. For anal pain, you can use the mnemonic Socrates to remember the aspect you need to explore. We need to know the site of the pain, its onset, the character of the pain, does it radiate to anywhere else, its associated features, which we will talk about it after this, the timing, its duration, its frequency, its exacerbating or relieving factors, and lastly, its severity on a pain score from 0 to 10. Next, for the bleeding, to assess the timing, you need to know its onset as it might differ from anal pain, its duration, its frequency, and its pattern. Is it always after defecation? For the blood itself, you need to clarify the color. Is it dark red or bright red color? How much is there, the quantity, and its relationship with stool. Is it mixed with stool, on the surface of the stool, on your toilet paper, or on the toilet pan itself? Next, we look at its stool. How's their consistency? Are they hard, are they soft or liquid in nature? Their color, is it foul smelling? And is there presence of mucus, shiny like mucus? When you talk about stool, you also need to assess their bowel habits. Their frequency, do they have constipation or diarrhea? Their need to strain when they defecate, urgency, incontinence, and also tenesmus, which is the feeling of incomplete emptying of your bowel, even though you have evacuated almost all your stools. Some other aspects in your history of presenting illness include presence of abdominal pain, itching around anus, upper GI symptoms such as nausea, vomiting, difficulty swallowing, and heartburn, some systemic features, fever, weight loss, loss of appetite, fatigue, and also some inflammatory symptoms such as mouth ulcers, painful red eye, joint or back pain. As the patient presents with bleeding, we always have to assess its anemia symptoms, which include dizziness, shortness of breath, palpitations, and lastly, because of stool-related chief complaint, you may have to assess their recent food intake and travel history. There are two main aspects for physical examination in such patient. They are digital rectal examination and abdomen examination. Digital rectal examination is usually not possible due to pain. However, if it's feasible, you may give analgesic before the examination, for example, oral tramadol, and wait for 10 to 20 minutes before you examine the patient. Do not forget to do abdomen examination for mass, as abdomen diseases often related to perianal condition. So as usual, you should inspect the abdomen. Is there any mass visible? palpate the 9 quadrants of abdomen, superficial and deep palpation, percuss if it's tympanic or dull, and lastly auscultation of the bowel movement. Let's have a quick recap on the steps in performing digital rectal examination. First, introduction. Introduce yourself to the patient. Explain to the patient the purpose of this examination, which is to detect any abnormalities and findings which may be useful for the diagnosis, and what the examination involves to examine their back passage. Make sure you reassure the patient that you can stop if it becomes too painful at any point. Request a chaperone for this examination. Next, preparation. Put on apron and gloves. Ask the patient to remove their trousers and underwear. However, cover the patient with a blanket when appropriate to maintain dignity. For position, ask the patient to lie on their left side and bring their knees close to their chest, and let the buttocks sit at the edge of the couch. And also ensure there's adequate lighting for good visibility during the examination. When you start to examine, you always start with inspection. Gently part away the buttocks and expose the natal cleft. Inspect the perianal area for any skin tags, any scars, any bleeding mucus, any fissure, any anal fistula, external hemorrhoids or rectal prolapse when you ask the patient to cough. Before you start to palpate, you make sure that you lubricate your examination finger. Gently insert your finger into the anal canal after you warm the patient, and assess the anal tone by asking the patient to squeeze your finger. After that, you shall carefully rotate your finger to feel all the walls of the rectum. In males, make sure you palpate the prostate at the wrist, and then you shall withdraw your finger and inspect contents for stool, mucus, and blood. By completing the examination, you should offer or clean the patient with paper towel, ask the patient to redress, and also wash your hand. And also you shall say that you would like to perform a gastrointestinal or abdominal exam to complete the whole physical examination. Now we have reached the second part of the video. Here we will talk about the differential diagnosis associated with the chief complaint. Some painful perianal conditions that I have in my mind include, firstly, hemorrhoids, anal fissure, anal fistula, and some other causes that are less likely, which include diverticulitis, colorectal cancer, inflammatory bowel disease, gastroenteritis, and upper gastrointestinal bleed. Before we look into each of the differential diagnoses, let us look at the perianal anatomy. Here we have a picture of perianal anatomy in the coronal plane. In the adults, the anal canal is about 4 centimeters long. We have anal column and also a dentate line which marks the boundary between the insensate anorectal mucosa superiorly and sensate anal canal skin inferiorly. We also have anal glands that open into the base of the anal column, which end at the dentate line. At the side, we have circular muscle of the rectum, which its continuation as internal anal sphincter here. And naturally, we have external anal sphincter, which is a continuation of the pelvic floor musculature such as levator ani. Essentially, internal anal sphincter is an involuntary muscle under autonomic control, while external anal sphincter is a skeletal muscle under somatic control. At the side, we have ichioanal fossa, which is a fat-filled space outside the external anal sphincter bounded laterally by the ichio tuberosities. And in between the internal and external sphincter, we have this intersphincteric groove. Our first differential diagnosis is hemorrhoids, which is the enlargement and displacement of the vascular occlusion within the anal canal. It often presents with painless rectal bleeding, which may be bright red in color, on toilet paper or drips into the toilet bowl. It may be associated with pain, pruritus due to mucus discharge, and rectal prolapse in severe cases. The causes include increased intra-abdominal pressure in pregnancy, constipation due to straining, coughing in asthma, and also straining in benign prostate hyperplasia. It is also due to portal hypertension in liver disease and increased rectal vein pressure in obese patient and due to prolonged sitting as well. There are two types of hemorrhoids, namely external hemorrhoids and internal hemorrhoids. External hemorrhoids arise from the inferior hemorrhoidal plexus beneath the dentate line, while internal hemorrhoids arise from the superior hemorrhoidal cushion above the dentate line. External hemorrhoids develop from the ectoderm, and it is innervated by cutaneous nerve, such as pudendal nerve and sacral plexus. Hence, it is painful when you get it. It may present in the setting of acute thrombosis and severely tender tense edematous mass. Pain often results from rapid distension of the innervated skin by the clot and also surrounding edema, usually following a specific event such as physical exertion, straining, or a bout of diarrhea. On the other hand, we have internal hemorrhoids that develop from the endoderm. It is not supplied by somatic sensory nerves, hence it's not painful. And we have severity classification for internal hemorrhoids. In first degree hemorrhoids, you get painless bleeding with no prolapse. In second degree, you get bleeding associated with prolapse and spontaneous reduction. Third degree, bleeding with associated prolapse which requires manual reduction. And the fourth degree, chronically prolapse and is irreducible. Our second differential diagnosis is anal fissure. It is a painful linear tear or crack in the distal anal canal and is defined as tear in the squamous lining of the anal canal distal to the dentate line. Posterior midline is frequently affected, in which about 90% of primary anal fissure occur posteriorly. In this case, physical examination is best performed by spreading the buttocks apart gently and looking carefully at the posterior midline. Findings include fresh laceration in the anoderm with sharply demarcated edges and involuntary spasm of the anus. The causes for anal fissure include trauma, such as straining in constipation, repeated passage of diarrhea, or following a vaginal delivery in women, which they will get anterior midline anal fissure in this case. Next, the clinical features include severe anal pain and is often associated with defecation. Rectal bleeding presents with small amounts of fresh, bright red blood, either on the toilet paper or on the surface of stool, typically separated from stool. And some other symptoms may include perianal discharge, which causes itching and skin irritation. In chronic anal fissure, it often exhibits some features such as external skin tags and hypertrophied anal papillae at the proximal end. Our third differential diagnosis is anal fistula, which is an abnormal communication, hollow tracts lined with granulation tissue connecting the primary opening inside the anal canal to a secondary opening in the perianal skin. It is usually associated with anorectal abscesses. Anal fistula and anorectal abscesses, they share a common etiology. Abscess formation represents the acute phase, with subsequent epithelialization of the tract, leading to the establishment of a fistula. However, not all anorectal abscesses go on to form fistulas. Some key points associated with anal fistula: a history of chronic recurrent anal rectal abscesses and fistula raises the possibility of Crohn's disease and tuberculosis. And of course, the clinical feature include intermittent purulent discharge and pain in the patient. It is essential to learn about the classification of the anal fistula and its associated good source law. For the classification, there are four main types of anal fistula. The first one is intersphincteric anal fistula, which is shown in line number 1. It only crosses internal sphincter and does not affect external sphincter. Secondly, we have transsphincteric anal fistula, as shown in line number 2. It has a primary tract that crosses both internal and external sphincter, then passes through the ischial rectal fossa to reach the skin of the buttock. Next, we have suprasphincteric anal fistula, which is rare. And lastly, extrasphincteric anal fistula that runs without specific relation to the sphincters and usually results from pelvic disease or trauma. Next, we have good source law, which indicate anterior opening tend to follow a simple direct course in a patient who lies in a lithotomy position, while posterior opening fistula may follow a devious curving path. However, there is one exception to the rule, which is that the anterior external opening lying greater than 3 cm from the anus may represent an extension of a posterior horseshoe fistula. Here comes our last part in this video, investigation and management. For investigation, we can get full blood count to look for leukocytosis in case of infection or the patient's hemoglobin level as he presents with bleeding, chief complaint. Next, we can take urea and electrolytes to look for dehydration. Examination under anesthesia is necessary for anal fistula for us to delineate the suspected fistula tract and abscess. However, radiological imaging such as endoanal ultrasound, MRI or CT scan is rarely necessary, but may be helpful to confirm the diagnosis. For the management, if the diagnosis is hemorrhoids, the primary intervention should be lifestyle modification, which we advise patients to take high fiber diet and improve fluid intake to ensure smooth bowel habits. It also includes behavioral modification, such as avoiding reading in toilet, excessive straining, and encourage to lose weight and to maintain good anal hygiene. Non-surgical management include rubber band ligation and injection sclerotherapy for hemorrhoids. In rubber band ligation, a small elastic band will be placed on the base of the selected hemorrhoid. This cuts the blood supply, and as a consequence, the hemorrhoid will undergo necrosis and fall within a few days, and the area will then heal naturally. On the other hand, for injection sclerotherapy, an irritant chemical solution, phenol, will be injected into the base of each pile. These sclerosants will induce intense inflammatory reaction, will then provoke fibrosis at the base of the hemorrhoid, causing the blood supply to cut off, and in turn the hemorrhoid will shrink and disappear. Surgical excisional hemorrhoidectomy is usually reserved for refractory cases to above procedures, patients who are unable to tolerate minor procedures, large external hemorrhoids, and combined internal and external hemorrhoids with significant prolapse. Next, we look at anal fissure. As usual, we need to advise for lifestyle modification to ensure soft and easily passed stool. You can add laxative or stool softeners if necessary. Topical lubricants such as petroleum jelly may be used for pain relief and soothing. Medical management is used for chronic anal fissure. topical glyceryl trinitrate, diltiazem ointment, botulism toxin injection. They will increase local blood flow in the anal canal and reduces pressure in the internal anal sphincter, which may further facilitate healing. However, warn the patient that GTN ointment may cause throbbing headaches and may drop their blood pressure. Similar to hemorrhoid, lateral internal sphincterectomy, surgical management only for refractory case. In sphincterectomy, 30% of the sphincter fibers are divided, lower the resting pressure of internal anal sphincter, hence improving the blood flow to the fissure. However, some degree of flatus and fecal incontinence may occur, quite often in the immediate post-operative period. Lastly, for anal fistula, we can use a cutting seton. The function of this seton is to provide drainage to induce chronic fibrosis and to cut the fistulous tract with preservation of sphincter function. The surgeon will pass a seton suture through the tract and the two ends tied together outside the body. A cutting seton is gradually tightened every 2 weeks over an approximate 6 to 8 week period. This allows fibrosis to occur and the tract to gradually heal or become low enough to be laid open. So for fistulotomy, it's a procedure where the fistulous tract is merely laid open to heal, and fistulectomy, which is a surgical procedure where a fistulous tract is excised or cut out completely. Let's look back at our patient. A 55-year-old man presents with anal pain and anal bleeding associated with dark red stool and bright red blood on toilet paper. On physical examination, you would see a palpable bulging dark red to purplish nodule at the outer rim of the anal canal. It is very tender to palpation. The diagnosis of thrombosed external hemorrhoids was made. For the management, surgical excision of the thrombosed external hemorrhoids would be the best for our patient as he presents within 72 hours of the onset. Patient would then lie prone and the butt cheeks will be separated using tapes. The skin will be excised and the blood clot would be allowed to drain out itself. We leave it and then we will do hemorrhoidectomy on the patient. If the patient presents more than 72 hours from the onset, we will have to consider conservative treatment, such as giving analgesia, as clots will often resolve itself, although it takes time and painful. After that, we should schedule an elective hemorrhoidectomy with the patient. Post-operatively, the patient should start with warm sitz bath using salted warm water as soon as possible. He should be doing it following every bowel movement for 10 to 15 minutes. Patients should be also given analgesics such as acetaminophen and ibuprofen. Avoid opioid analgesic due to the constipating action. Patients should be kept well hydrated and add stool softener for the patient to enhance bowel movement. Patient upon discharge, we should schedule an elective colonoscopy with our patient as he also presents with dark red stool and due to his age. And it's necessary to follow up with the patient to see his well-being after that. That's all for today's video. If you find the content helpful, do not forget to hit the like button and subscribe to my channel. Thank you and have a nice day.